Take it away.
Great. Hey guys, thank you so much for joining yet another episode of our Zoom meetings. I wanted to first start out by thanking everyone who came to the Medical Director Roundtable. We had a good time. And for those of you who joined, I'd love to hear any feedback. You can chat it in or just say it out loud. I thought that we had a good, robust, interactive discussion. There was definitely some questions that we got that we actually built some structured conversation around. Which really helped because then we kind of had our own little choose your own adventure where you could just kind of we just clicked on the screen and just brought up the slides of different topics. And each of the medical directors talked about different things. We talked about everything from EKGs to STEMI management to, I can't remember. It is now much more of a blur, but it was a fun discussion. I think we hit a lot of things and then we fielded some questions along the way. Any feedback from the group? Anyone who wants to say anything or put in the chat? Oh, the one consensus was that people want to do it more. They like that version as a different alternative to our regular Zoom meetings. So we're talking about maybe doing this every once in a while to change things up. The chief is, yeah, thanks, Chief. Well, today we're gonna go back and do a little bit of touch base like we normally do. I do want to touch base on the most recent SIM because I think it hit a lot of different concepts, and I do want to highlight a couple of major concepts because I didn't make all of them, but I made a lot of them. So let's talk a little bit about them. So we're going to touch base on the first quarter SIM this last time. And we had some clear learning objectives this time about really thinking about how we manage chest pain in high risk situations. And we really wanted to push you guys to start thinking about scenarios where you're moving towards push dose pressors or needing to do pacing. And what are your alternatives to pain management and sedation in those kind of situations? And we presented a very straightforward guy at first. It's a 64-year-old guy who has chest pain. He was mildly confused, anxious, but his airway was fine. His breathing was okay. He would still talk to you. And he just was completely fatigued, just laying there on the couch. And this was your first set of vital signs, which are a little concerning, right? He was 88/52, satting 92%, which was not, I wasn't totally stressed about that, but the 88/52 for a guy who's 64 years old, who probably is supposed to be on antihypertensives and all this kind of stuff, is definitely concerning. And then, of course, we hit you with this. We hit you with the EKG that I think we've all seen and evaluated as we've gone through this. But more importantly, as we looked at these EKGs together, we saw the traditional trend that we see of the 2-3 AVF leading us to thinking about an inferior MI. Now, in this EKG, what I think is kind of interesting is that you don't have tons and tons of reciprocal changes here, right? But it's still so impressive that it really directs you to moving in the direction of thinking of that STEMI, right? And again, just to kind of revisit the concept, there's some very nice ways that you can learn to memorize these for yourself or just kind of get used to the concept of where they live. But with our inferior MI, we're thinking 2-3 AVF. And one of the things that I love about what I believe Keating did with this particular slide is he put RCA greater than left circumflex to kind of give us an idea of what the blood flow is going to these areas where you have LAD in these areas. And that's just giving what is feeding into these different beds, which becomes important. When we think about this 2-3 AVF section, the other thing that we kind of start thinking about immediately is, should we do the right-sided? Is this just inferior or is this right ventricular also? And so in this case, V4R was done. So they moved that little electrode over and took the other side. And yes, indeed, we're seeing still an elevation over on V4R, giving us an idea that this is right-sided. Now, we talked a little bit about the normal stuff that we do. And one of the pauses that we gave and we talked about in detail is the use of nitro, specifically because of the amount of preload that you may have, right? So if you have an inferior MI with the right-sided problems, preload is a problem because now the right ventricle is functioning as a conduit, not a pumping system. And that is a real problem because as we give nitro, it drops your preload and makes it such that now that conduit is not having as much of a head pressure to bring fluid in. Very much the concept of fundamental plumbing. And so with that in mind, we try to avoid nitro. Now, the other question that we we posed to every group was the concept that, does nitro really change outcomes? And fundamentally, unlike aspirin, where we know we have a 50% impact on survival and functional outcomes, nitro doesn't have any impact like that. No survival benefit from nitro. So you don't have to stress out that I'm not giving nitro because this person's hypotensive. I think it's a function. It is definitely one of the things that we find different from our opiates, which will give pain management, at the same time have a theoretical benefit of dilation of the coronary arteries. So all good things. Unfortunately, we never saw a benefit in survival. So then the patient gets sicker and becomes more altered. And this was a scheduled event in the care, and they went bradycardic on us. And so now you have a STEMI with significant bradycardia. And you can go through and count up where you're at here, or you can cheat and look up here and see it's 43. Just from the counting purposes, because sometimes it's just faster and easier. You can just take a line and go 300, 150, 100, 75, and just junk. So literally what I tend to do is anything more than 4, I know they're bradycardic, because that's 70. That 4 is my 75 mark, and so that's my keep it simple, stupid method for myself. And if it's 4 or if it's greater than 5, I know they're symptomatically bradycardic if they're hypotensive. And there's my line, and do the calculation. So what's going on? So this is the other piece that I wanted to start pushing us towards, is really thinking about a little more pathophysiology. Why do things happen? And why are our bad outcomes leading us towards worse outcomes, right? And in this case, we have a right ventricular and inferior MI, which affects the AV node. So this is the important concept of the bridging between our vascular structures in the heart and how they affect our electrical structures in the heart. So this was the big fundamental teaching point for the pathophysiology piece that I really wanted to put out there. And so when we think about this, these conduction deficiencies are completely related to what vascular supply is going to the bed. So when we talked about that right side, or that inferior MI, we knew that the large amount of that is RCA, right? Almost 90% is fueling our AV node, whereas our SA node is getting a little bit of a mix with the left circumflex coming over. Now, the most important concept then is, if that side is getting all that blood, on the opposite side, in the septal side, all of that's LAD. So that septum of the heart, where you have the Purkinje electrical fibers going right down the middle, which is the main thing which does great contractility to the left side, that is all down that septum, and that's all LAD. And so if you have a large LAD lesion, you know you're going to have a big issue there. And so with these inferior wall MIs and with our right-sided, you should expect lots of nodal involvement and lots of different types of bradycardias and stuff like that. The good part in general is that they will generally resolve. So if somebody's bradycardic or throwing PVCs and things like that on you, don't stress over it. If they get so bradycardic, you want to give a little atropine, a lot of times it'll work, and it's worth trying, right? Over time, these will resolve as the edema from the STEMI resolves after you do reperfusion. But in this situation that we presented you, the hypotensive and bradycardia that you're getting because of the extent of bradycardia, that is a pump issue at that point because of filling, and you're going to have to do something about it. And so just to close the loop, when we're on the other side of the heart and you have the LAD lesion affecting the septum, expect big problems, because you have necrosis of strong conduction tissue, and that is the main pathway. So you're going to have higher end blocks, 2nd and 3rd degree blocks, which will basically have. And so anytime I see those kind of STEMIs, I'm always putting the pads on just for the safety's sake. Oh, thanks for the clarity, Glenn. So go Scott. Okay, so when we think about the options for hypotension and bradycardia, we have a couple different options. And actually, I'm just going to push us to the protocol. And in the protocol, we manage the basic stuff: universal care, airway, moving down to actually taking care of blood glucose and hypoglycemia, because oftentimes that can actually be a source of some of the problems that we have, because people can have normal unsymptomatic bradycardia and be symptomatic because they're hypotensive, not hypotensive, hypoglycemic, right? So let's fix that, make sure that's not a problem. And then now you're into the realm that we have different issues. Are they have a systolic blood pressure, which is normal, and so we can just give them a little bit of fluids and transport them? Or is their systolic blood pressure low, and that's posing a lot of new problems? The first part of that management strategy, of course, is giving atropine. Will it work? Yeah, sometimes. you'll notice that we increased it from 0.5 to 1, which is consistent with the AHA guidelines. The other thing here is we have calcium gluconate here. Calcium functions as an inotrope. So you can give some calcium in the hopes that it'll stimulate, because it actually stimulates to another alternative pathway. For those of you who are utter geeks like myself, it's a cyclic AMP induced pathway. And so that would be a different way of stimulating the heart rather than doing beta stimulation. And so that's another opportunity that you have. Definitely in your dialysis players, this is a great way to go, because you'd also be managing hyperkalemia, which causes symptomatic bradycardia, right? So definitely a good approach. From there, now we get into the realm that things aren't working, we need to do something about it. You can think about pacing, or you can think about epinephrine. And we had a lot of robust conversations about which one of these to do, right? So if I pace them, I'm probably not going to increase their myocardial oxygen consumption by whipping the dying horse of the heart because they're already having a STEMI. Well, that's exciting, right? That makes sense to me. But at the same token, as we stimulate the heart to higher rates, we are going to increase myocardial oxygen consumption no matter what you do, right? So half of one, half the other. There's never been a study which has compared the two between push dose or pressor approaches to bradycardia management versus pacing management. So I can't really give you an idea of which one's better. Just we need some blood pressure, right? Let's give it a try. And it was kind of cool to see that some people tried different approaches. Some people said, you know what, I just want to start with, I got a line, I'm gonna use my line, I'm gonna just give them some push dose and give it little by little and see where it goes. And then sometimes people would switch to pacing if it didn't work. Or people just said, you know what, pacing is so much faster, I'm just gonna pace them. Quick, easy, and then give them some sedation. And that was one of the challenges with this case, is how do you sedate a hypotensive person? Because giving them a bunch of Versed is just going to tank them. If you guys gave him 5 milligrams of Versed on this particular approach, by our a priori decision, the person tanks, because 5 milligrams of Versed is a good hit, right? If you gave 1 to 2 just to give them a little bit, they probably would have been done okay. The other alternatives, of course, is just treat the pain. Give them a little bit of fentanyl just to make them a little comfortable, like 25 to 50, something like that. And the new approach, of course, would be to give them a little ketamine, where you can get a little bit of pain management. Now, keep in mind, this is not sedation dosing. This is low dosing. And so this is a 0.2 mg per kg for just pain management. Keep in mind, sedation is more like 0.5 to 1 mg per kg. So big difference, right? But you'll still get some good pain management from that. Talked about atropine already. Push dose wise, push dose, when you think about push dose pressors, I want you to think about it in the framework that this is all part of a resuscitation strategy, right? Obviously, at the same time, you're going to be getting push dose, you're going to fill the tank, because pressors don't work without something in the tank, right? And so give them a little bit of fluid, and then you can go with your pressors. There are some there are clear ways of using this, and it's great. This little green little thing makes it really easy to mix it up. And I have these cheesy little images. I don't have it here right now, but you can actually fill the syringe with one, and then push it through, and you'll have your dilution, which you need. And of course, just in case of shortages, just dilute it twice from 1 to 1,000. Good data when it comes to what it's going to actually do. And so we definitely see a MAP increase by 13 points. And heart rate in this case didn't change much. But one of the caveats I told everybody as we're going through this is that these studies were done in patients who are often septic. So those septic patients are already having lots of sympathetic stimulation. They're already tachycardic like crazy. And so being tachycardic like crazy, they're not the classic bradycardic patient that you're going to give the push dose and see the heart rate come up, which is why you only have a 1.5 benefit. The cool part, though, which I really want to indicate here, is the corrected hypotension happened in almost 60% with one dose of 10 micrograms. So that 10 micrograms is pretty powerful when we think about the utility of it for our patients. Again, here is just from the unified protocol how we use it. Here's your 1 cc mixed up with your 9 to make your nice little dilution of 10 micrograms per ml. And then just keep that in your pocket and give little by little. The other thing we reviewed, of course, is how to pace and going through the different steps for pacing. I think the biggest thing I want to indicate here is just think about capture, right? You want to get true mechanical capture where you have a real rate you can feel on your fingers. One of the challenges that was part of this scenario was the fact that as you're increasing your output, there's a space of time where you will go from your low bradycardic rate to something which looks like AFib on the monitor, right? It's going to have rates which are like 120, 150, 110, 105, and it's jumping around like crazy. And that is the concomitant rhythms that you're seeing. You're seeing the baseline bradycardic rhythm, and overlaid on top of that is the 70 output that you have from your pacer before you have mechanical capture. And that's what's giving you that AFib. So expect that when you're starting to turn up your output. And then as your output comes up and you get true capture, that goes away. And now you have that base setting and you can feel your pulse at the same time. Sedation, we started talking a little bit about this, about the different approaches. Obviously, you can use the Versed we talked about, ketamine as an approach with a maximum dose of 25. And last but not least, thinking about the fentanyl as another option. The last thing we touched base across the board was for everyone's purposes of dosing of ketamine. So we have three basic ways and approaches to use ketamine: the pain management, the agitation, and the deduction RSI dosing. And so for all of these, you got to think about how you want to use this. Are you going to use it straight out of the bottle, or are you going to do the dilution? The dilution is the same for everything, 1 to 10, right? And in this case, if I was going to do adult pain management, straight out of the bottle is a really, really small amount, that for like a 75 to 100 kilogram person. So in this case, I would dilute and be able to give like a mil or 1.5 mLs to the right size. When it comes to agitation, use it straight out of the bottle. Makes more sense, because if you try to do anything else, it's just way too much volume. And when you're thinking about RSI, you're right in the middle here. You could do either approach, and either approach will work, because with straight out of the bottle, you're using 1 to 2 mils. But if you're using the dilution, you're using almost 7.5 mils to almost 10 to 20 mils. That's kind of normal of what we would give through an IV for a sedation type dosing. So that's something reasonable. So both approaches work in this case. Again, keep in mind, you have the fun little piece that you can use here to actually do the mixing. And so definitely use that piece. The biggest thing I want you guys to take away, and I'm coming up down to my time here, because I try to keep it around 15. Ketamine is an addition to our current practice. When we look back at agitation and management of agitation at our agency, we used Haldol once last year to really put somebody down. And so the use of ketamine is probably not going to be as evident when it comes to agitation and sedation as in other locations. It's just not a high population piece for us. However, with that being said, it is nice to have the alternative. You don't have to use it. Use it when you get more comfortable. But the cool part with ketamine, which is really nice for us, is you still gives you tons of options. And it's one more option that is available to you. I'm not one who is big on tons of tools in the toolkit. But the thing is, ketamine does open up a lot of options for us when it comes to resuscitation, which is why I'm excited about including ketamine. Because the next goal will be thinking about delayed sequence intubation, where if we have somebody who's really sick, hypotensive, hypoxic, and we need to resuscitate them a little bit before we try to tube them, ketamine's a great option, which may help you not lose the airway while you do your resuscitative efforts. We'll talk more about that in the future, but that's just kind of the concept and the direction that's going. So with that being said, I am open for questions and discussion. You guys, in general, I am so proud of how we perform on these. We've had a number of visitors who came through the sim lab and who are excited of working with us through our sim lab. Nationwide Children's Hospital came through and they wanted to see exactly what we're doing so they can enhance some of their simulations that they're doing. And we have now submitted a grant for device testing using our sim lab. And so there's a lot of neat things that are coming through the sim lab, but the best part of it is we're continuing to enhance our education. And that is the biggest thing. I know that it gets stressful sometimes, but I love the fact that you guys are just sucking it up and making it happen. It's just a great training venue for all of us. So thank you again. Any questions I can answer today? Well, cool. I'm going to pass it over to the Chiefs. Thank you guys very much. Chief.
Morning, everybody. I am home today. I had the day off, got my mother in town, and I got to take the kids to doctor's appointments. So wanted to jump on and do a coffee with the Chiefs. Great job to the clinical team for the sim lab this quarter. Not only did we have nationwide children's come through, but we had another EMS service from another state come through and try to learn how we do things so they can improve theirs. Kind of cool. One of the big nationally known paramedic programs follows us and asks us a lot of questions about our simulation house. Eastern Kentucky follows us and asks us a lot of questions about our simulation house. They're interested in doing something just like it for their students. So kind of neat, it's great to see the time and money and effort that we put in the sim lab for our providers is also helping people outside of our agency. So big shout out to Lieutenant Berger. We are working on completing CAS, and he has been working diligently on that with myself and Chief Burgess and anybody who he needs to get information from, which is a lot of people throughout the county. So obviously he's done outstanding work on that. He works really hard on it, and he should be publicly recognized for that. We'll be submitting for our resubmission here soon. Submitting for our reaccreditation soon. And that's what we've been working on a lot of. Also, since the last time we talked, we've been hammering out updates and revisions to the SOGs. And thank you, Thomas Beglinger, for pointing out that I believe one of the 400 series, I had accidentally posted a duplicate of a 300 series. So or maybe I had that flipped, but there's a duplicate posted. So I will go in and fix it. And thank you, Thomas, for letting me know. With that being said, I believe that's all I have for this time around. Just lots of CAS stuff, lots of SOGs, and I believe that's all I have.
Chief, there's no way to bulk sign those. Those have to be signed off individually, correct?
Chief Burgess.
I'm going to touch on that here in just a second. So.
Okay.
Yeah, Chief Burgess and Captain Davis are working on that, because as of right now, no, but they're working on that. Because when the 100 series and the 200 series come out, there's going to be quite a bit. But that's all I have, Chief Burgess.
Cool, thank you. Just touch on that, Captain Farmer. We are going to, and maybe today, I'll get those done, but we're going to, the 100 and 200, there'll be a form on EMS Manager, and it will have each of the 100 series on a form and each of the 200 series on a form, and there'll just be a checkbox for each one of those. So you'll just have to, check the box for each one of them when you're all done reading them all, and then just sign at the bottom. Otherwise, we would have, there's about 60 total SOGs, I think, and if we have everybody signing 60 of those, that's a lot. So we're going to just do one form for 100, one form for 200. You'll just click on each one, and then once you're all done, you will click on them and then sign the bottom that you have read and understand and acknowledge the SOGs. And then that way you only have to fill out one form versus 60 forms to get those SOGs done. The 300 and 400 will be individual, just like they're already set up, but there's just a couple of each of those. And then the 200 will be one form for each series. And then each individual SOG will be listed out on that form. So anybody have any questions on that? All right, cool. Also wanted to congratulate now Captain Steve Kosis. He will take over. There'll be a little bit of a change on the operations side with the captains. Captain Moore is going to be moving to one unit. 462 one unit, and then Captain Kosis will be 462 on 3 units. So that'll begin Beginning of next pay period. So the 20th will be Captain Kosas's first day, and then the 21st will be Captain Moore's first day on one unit. So, but I believe he's on vacation for the first 3 days. So, and then also after that, we'll also get congratulations. Andrew Lunn will also be promoted to lieutenant. I'm not sure where he'll end up yet. We've got to get the postings done. Matthew Brandt is moving to Station 6, and so we have his spot at Station 8 is posted right now. So once we get those done, we'll have an idea of where Andrew's going to end up after we get the Medic 10 posting done, and however that works out. So got a little bit of moves going on right now that we'll should be done with here in the next week or so. Also with run statistics, when we switched to the new CAD system, we essentially lost our ability to pull run stats like we used to. Patrick, Brandon, and Matt and Jason Montgomery from IT have been working really hard to pull that data out of that system and get it into a format for us where we can pull it out and get what we need. So I think finally on Wednesday, we finally were able to get that done. So today we're going to mess around with that and should be able to start sending those operations run stats back out again, at least with January and February. So I just got to play with them and make sure everything's correct. And then we'll start sending those out again so you guys can see how we're doing. So I believe the last thing I have is we've got the COT service scheduled. And I don't remember off the top of my head when Justin has that scheduled for, but you guys will have to rotate your, the east side will rotate through Station 7. And I know one of those days is on a 3 unit, and then the other day will be Station 1 for the west side of the county.
The 22nd and 23rd.
Okay, thank you. 22nd and 23rd of March. So we'll rotate those trucks through if you're working those days. And I believe that we'll have the stock backup truck there for you because it'll take about an hour to do the cot and the stair chair. So I think we'll have the stock backup truck there for you where you can swap that stuff out. And, but Justin will have more details on that, Justin and the captains as we get closer. So I believe that's all I have. Any questions? All right, Chief Cochran, you're up.
Good morning, everybody. Just a couple things. The fitness team is going to be sending out the new equipment that we have next week. That at least that's the plan, as long as everything goes well. Justin will be teaming up with Andrew Lunn to make that happen. And of course, all the people on the fitness team are making themselves available to help with that. So you'll see them at your stations. And we're going to be testing on Monday and Tuesday for new hires in the morning and the afternoon in the EOC. And we have 35 people. We actually had more than 35 people, and Director Fisher went through and made a selection. So it's pretty exciting that we have so many candidates. I know you sent out an email that said it's about half and half. Victoria Chris Stottlemyre is now a paramedic. I'm sure everybody saw that email. Yes, we're really proud of her. She went through the FTO process. She also went through the credentialing. I can't talk this morning with Captain Gano, and he called yesterday, and it was a wonderful call to hear him tell me that she passed. I know that she also got some encouragement and help from a lot of you. Jason Sudermaster, I think, was a positive influence on her. So thank you for everything that you're doing to help your fellow crew members and the employees of Delaware County EMS. We will be tag on to Chief Burgess's little message about all the different moves. So when those moves all are completed, we will be hiring to fill those spots. We'll also be hiring a full-time paramedic to fill the 3-unit floater spot. So very exciting. And we'll also be filling in some spaces for part-time paramedics and EMTs as well. So both positions, full-time and part-time. anyone have any questions? Oh, one more thing, the PAS is going to be this summer. It's slated for June, hopefully, possibly July. You will do it off duty. Bryce is working on changing it. We actually need to schedule a meeting to talk about his ideas, but he wants to make it more functional, a lot like what some of you have requested, to make it more realistic to what your job is. So applaud to Bryce for always thinking ahead and wanting to make this work for all of us. That's it.
One quick thing from me before we wrap up is since we made the changes for our masking mandates and all that kind of stuff, I'm kind of keeping a close eye with the chiefs and the captains about what our counts have been when it comes to exposures and things like that. So kind of keep that in the back of your head. We are just going to kind of keep a close eye on it. I know we had a couple more exposures recently. And so those are still being discussed, and we're always looking at these numbers. So we'll keep you guys posted as we get more information.
One last thing, Captain James, are you on?
I am.
You want to give a kind of a update on yesterday's meeting? But before you do, one thing I wanted to point out to everybody, we met with our uniform supplier, and they brought in one of their vendors. Their vendor is a Delaware County resident, and the first thing he wanted to let us know is he lived in Delaware County for a very long time, and he talked about how he's always seen our ambulances going up and down the road looking meticulous, and they scream professionalism to him whatever they're driving by. So I wanted to pass that along to all of you, because he wanted to pass that along to us. He lives down in Genoa Township, so he's used to seeing the ambulances down in that area. But he's well aware of what's ours, what's the fire department's, and he knows about our new station and all that. So anyway, just wanted to pass along some positive feedback we got from one of the suppliers. Go ahead, Captain James.
So who he's referring to is Mr. Schertzinger, who works for Fetchheimer. And Fetchheimer is the producer of Flying Cross apparel. We met with him for, Fisher and I met with him for about 2.5 hours. We went over several different options as far as pants. If you remember when we started the uniform process 2 years ago, we talked about branding, and then we talked about longevity of our uniforms, specifically in the area of fade. We've taken care of that, we think, with the pullovers and the polos. So the next charge was let's see if we can get into some pants that will allow us not to have the fading issue and constantly ordering of the pants we currently use. So we're going to do a trial run. We're going to have a fitting 1 unit Medic 1. It was decided on will be our test subjects. Lieutenant Moore, Lieutenant Sarah and Julie, and then Captain Atkins, and then Justin Lowry for 40 hours. And then there's going to be one more, and we haven't decided who that one more is going to be. But anyway, so long and short of it is we're going to try them for a month. They're going to be fitted for them. There'll be 2 different kinds. I'm not going to get into what kind they are right now. I really want them to go into it with an open mind. The goal here is to get pants that's not going to fade. That gives us some longevity. The pants we're looking at, both styles of pants that we're looking at and how they're constructed. One lasts approximately 5 years per, they say, with very minimal fade, and the other one is 3 to 5 years with minimal fade. So it'll be an expensive outlay to start with, but the cost savings over just in 1 year, over a 1 to 5 year periods, incredible. So we're looking at that. And then summer shirts, they are giving me a mock-up t-shirt of the summer shirt. It's going to be our 50th anniversary. You saw the logo. It's on First Arriving. If you see that, that's the logo that'll be on the t-shirt. If you haven't heard me talk about it before, it's going to be a one-off t-shirt. So this will be the only year that we have that style of t-shirt. Everybody will get two. We're going to use the same branded t-shirt we use for the workout shirt. However, we went to just a different series in that, so we can also get talls as well. So you'll be able to order talls as well. I think it's XL tall to 5X or whatever we need. So once I get the mock up on that and official goes ahead and gives me the okay, we'll go ahead and get those orders and we'll get people sized and then we'll get those distributed out. Like I said, this year for t-shirts, it'll be a one-off. And then after that, with the fitness team and some other people, we're going to design a fitness shirt and a summer shirt that's all in one. So we have one design so I can get them in bulk and hand them out as needed. So that's all I have.
Yeah, and a big thanks to Lieutenant Reese for designing that 50-year logo. It's going on the shirt. It's on the challenge coin that we have. I'll have on that. Just so you guys know that the pants, you know, it's about durability, longevity, but also comfort's important to us. That's why we're trialing them. Otherwise, we would just select one. And they're going to go on like Captain James said, they're going to go on field providers and 1 40-hour employee. And that's that. All right. So any questions about anything? This is Coffee with the Chiefs. Am I the only one who ever drinks coffee during this?
I have my coffee.
There you go. He's got coffee. Thank you. All right. I don't see any questions. Let's see. Let me check the chat. Okay. I don't see any questions.
Hey,
Yeah.
hold on for a second. Dr. Ross, do you have a white Class A hat?
Nope. I need some love.
Okay, I need your hat size or you'll have to come in and get fitted for one, okay?
Size 11 to fit all those brains on his head. That's it. All right. See you guys next Friday after next.